I was invited to give two short presentations, and then we had a debate that was case-based, and in addition, I had the opportunity to do a Meet the Professor session. So our sessions were focused primarily on what the best therapies are to ensure normal growth in children with inflammatory bowel disease, particularly Crohn's disease, who tend to be the children who are mostly affected. So from the discussion, we suggested that there's really two approaches that seem to favor normal growth. So one is exclusive enteral nutrition, and this is an approach where we use defined commercially available formulas, and we offer these formulas for 8 to 12 weeks at a time. And the important issue, and the issue that was really underscored during the talks, was that it needs to be exclusive. And even though this is very effective therapy, the exclusivity of having to drink or receive by nasogastric tube feeding a defined formula for 8 to 12 weeks may not be appealing to some patients. However, from the medical perspective, strictly speaking, it is really a wonderful therapy to induce remission, and it's a wonderful therapy to ensure growth and successful progression through puberty. And the other approach that we take is biologics, and the biologics that we have most experience with regards to growth is the anti-tumor necrosis factor alpha agents, and among those particularly infliximab. So these are agents that have shown time and time again that they induce bona fide catch-up growth, meaning that they help the patient reach their genetically programmed final adult height. Unfortunately, with the more standard approaches that we used routinely 10 years ago, which is induction with a steroid followed by an immunomodulator such as thiopurine, we really don't see catch-up growth. We can see weight gain, we can see improvements in general well-being, but growth continues to be affected. The other aspect is that growth is a complicated thing to measure. One would say, well, you just put an individual against a tape measure, measure their growth, and that's sufficient. But we're learning along the way that what we really need to be focusing on is how fast that individual is growing. And in addition, we need to know what type of growth are we attaining. So what I mean by that is that weight gain per se may just indicate accumulation of fat and not a more desirable accumulation in lean tissue such as muscle. And that deficit in lean body mass and muscle mass can affect patient outcomes down the line. And of course, like we discussed before, the issue of puberty is also important to us. So ensuring a normal puberal progression is good for general health, is important for patient self-esteem. What's going to happen next is that we will be more aware that we need to institute some of these measures really earlier in the course of the disease. I think there is a narrow window of opportunity if patients come in at 12 to 13 years of age. In girls, growth in height tends to stop at about 15 years of age, and in boys, around 17 years of age. That's not universal. We know that some individuals grow later, but that's kind of an average rule, so that offers a window of opportunity that is relatively narrow, 2 or 3 years in girls, maybe a little bit longer in boys. And if we don't institute these therapies early in the course of the disease, then that individual is not going to do well as far as their growth potential is concerned. They may be permanently stunted. So that's obviously not what we want. So there was a second presentation that has to do with how best to approach children who are in the hospital with acute severe ulcerative colitis. And this is a presentation that is coming up today, but I think the debate is whether do surgery earlier versus offer medical therapy, and clearly there is benefits and downsides to both approaches. And I think at the end of the day, it really depends on a frank dialogue between the physician and the family as to choosing the more personalized approach. And I've had patients who wanted to avoid surgery at all costs, understanding the risks of some of the medications that we use, which people need to be careful and know how to use them. And other patients say, well, I'm done with medication and I want my colon to be removed. I want to be cured of this disease. So I've had patients on both spectrums, and it really is a dialogue with the family. So this has been really a wonderful conference. There are a number of talks both in the basic science arena as well as in the clinical arena that have been quite informative. I think the meeting is growing in attendance and in content every year. And this is a very rewarding experience for someone like me who likes to have a foot on science as well as in clinical medicine, because I have a lot to learn every time I come here.